it's my pleasure to introduce Dr. Matt Mell. I think for most of you, he's not a new face, but came to us a little over a year now as our chief of vascular surgery. We were fortunate to recruit him here from Stanford when our long-standing previous chief retired. And Dr. Mell has an interesting history. He went to medical school at Harvard, went back to Stanford for his training, actually did a transplant fellowship before starting his career actually in private practice or in the Kaiser system. After a few years in the Kaiser system, realized he really missed academic medicine. I don't know if that's totally the story, but that's how I'm going to spin it. And sought another residency in vascular surgery. I think was doing a fair amount of vascular in his role as a general surgeon at Kaiser. Went to Wisconsin, where he did his vascular training before getting recruited back to Stanford, where he then joined the vascular faculty there. But along the way, and I think mostly during your time in Wisconsin, really gained expertise in training and health services research and became really known academically and internationally as a health services research leader. And we've asked him today to give us an update on his experience in that arena. So thank you very much, Dr. Mell.
Great. Thank you. This is working. Can you guys hear me? So I do have an interesting background. I'm actually scheduled on slate to give grand rounds in October, and that's going to be more of the topic. So if you're interested in my very bizarre pathway, stay tuned. For today, this is really sort of a tag on me at grand rounds for those of you who saw the emails. I'm going to spend some time talking to you about my interest in health services research, and I'm going to start out by talking about my specific interest in screening for abdominal aortic aneurysms, but I really want to use this talk to motivate you to think about things that you can do. I'm going to show you some techniques that we've used that are really very applicable to various and wide variety of areas of research that can really have an impact. And so I want you to really think about how you could use some of these ideas and techniques in your own areas of interest. So just as a really brief introduction, abdominal aortic aneurysms remain prevalent in the world and in the United States. Aneurysm-related deaths are around 40 to 50 deaths per million on a yearly basis. There's about 15,000 documented deaths per year by mostly ruptured aneurysms. And there's an estimated another 15,000 deaths per year from based on autopsy series in other countries for yearly sudden deaths. So it remains a significant problem. We know that aneurysms repaired, if they're intact as an elective operation, is an extremely safe and durable operation. Operative mortality somewhere around 0.5% to 3%, whereas if the aneurysm is ruptured, the operative mortality is somewhere between 35 and 50%, and the overall mortality is probably still around 75 or 80% because many of these patients have free ruptures and never make it into the hospital. We also know that aneurysm rupture is directly related to diameter. The larger the diameter, the higher the likelihood of rupture. And so the idea, which is not new, is that aneurysms should be identified and treated before they rupture so that we can avoid the rupture and avoid the high mortality associated with rupture. And so these concepts sort of led to the idea of screening. And this has been studied for, about 20 years now. And when I talk about screening just as a background, I'm talking about ultrasound exams. So people have looked at physical exam for screening, and it's really not a very good exam. It's not good from a standpoint of either sensitivity or specificity. There's obviously an impact on the BMI, on your ability to do a physical exam. and also a lot of elderly patients who have tortuous aortas may appear to feel like they have aneurysms because of the tortuosity. Ultrasound, on the other hand, is highly specific and highly sensitive, and it's really by far the study of choice for both screening and surveillance. And so for the rest of this talk, when I talk about screening, what I'm really talking about is screening ultrasounds. So this is just, a brief background. So there's great data that shows that screening is clinically effective. It prevents aneurysm-related death. It reduces the rate of rupture. It increases the rate of surgical repair, not surprisingly, because it can identify more aneurysms that need to be repaired. And interestingly, it decreases all-cause mortality. I'll talk about that in a minute. This is just a slide. This is a study that was first published in 2002 and then updated in 2012. What this shows is that the blue dotted line, which are patients who were offered screening, this is in the UK, had a 45% reduction in aneurysm-related death. Very interestingly, they also showed a 3% decrease in all-cause mortality, which is highly unusual. Most screening programs are designed and are effective at achieving disease-related mortality. It's very unusual to see a screening program that decreases all-cause mortality. And the reason why we think this is because of the link between aortic aneurysms and coronary heart disease. There's data that shows that an abdominal aneurysm is a marker for increased mortality, and even small aneurysms have been linked to an increased death. Aneurysms greater than 3 centimeters have a twofold increase in 5-year mortality compared with controls. And because of this, it's thought to be a CHD equivalent, and because of that, when these aneurysms are found, these patients, it sometimes acts as the portal for patients to get good cardiovascular risk reduction management. And this is the thought behind the improvement in all-cause mortality from the screening programs. This is some data. This is a meta-analysis looking at the effect of statins. This study was actually originally designed to see if statins decrease the rate of aneurysm growth. It turns out that it did not. In fact, there's no medications to date that have demonstrated for sure a decrease in aneurysm growth rates. But they did find that there was a significant mortality benefit. And so you will see for us, when we see patients with aneurysms, one of the first things we make certain of is that they're on high-dose statins, and there's very good data to support that to improve their overall cardiovascular health. We actually studied this we had a prospective multicenter cohort of patients with small aneurysms in the Bay Area, and we wanted to see if this was true, that these patients, how their mortality compared to national benchmarks. And we had these patients with small aneurysms, a 2-year follow-up, and we did a standard mortality analysis. And I apologize, the text on this is small, but the point here is that these were from 3 different hospitals. These were very well-managed patients. Over 3/4 of the patients were on statins. Less than 20% were current smokers, even though 85% of them were former smokers. And for those who are diabetic, their mean A1C was 6.8. So these were patients who were very well managed. What we found was that, let's see. Nope. I'm gonna figure this out. Here we go. The solid line was the 4-year mortality of our patient cohort, and the dotted line is the expected mortality based on national vital statistics adjusted for age, sex, and race. So what we basically showed was that our cohort, even though they had aneurysms, they were well managed, and their survival actually outpaced the national benchmarks. This is just the data in table form, and basically the benefit in survival was better each year, 5% in the first year, 7% in the second year, and almost 10% in the third year. And so what we found was that these patients, about a third of them died of cardiovascular disease, but most of them were not related to their aneurysm. About a quarter of them died from cancer, and about almost 50% died from either other and unknown causes. We also found that the smaller of the aneurysms, less than 4 centimeters, had better survival than those who were greater than 4 centimeters. This actually wasn't new. This confirmed previous studies. So we have evidence that screening is certainly clinically effective. There's also good evidence that screening is cost effective. Now, in the United States, cost effectiveness trials studies are unusual, and they're not really used to determine policy. But in the UK, these are very common, and there's been many publications in Europe and the UK which basically showed this quadrant is where you get beneficial effects over the cost per quality adjusted life years. And basically what this showed is that it was highly cost effective to do the screening. There was another study that looked at age and cost effectiveness, and basically what this shows, and this was an older study, so they used $60,000 as the threshold. Typical studies now will use $100,000 as the threshold, but what they showed was that below age 85, there continued to be cost effectiveness with an average cost of about $11,000 in this study. And at this time, that compared with screening mammography, which had a cost of $16,000 per quality of life year saved. So it's certainly, for most patients, it's a cost-effective study. So this all led to some health policy milestones. In 2005, the U.S. Preventive Services Task Force recommended a one-time screening for men aged 65 to 75 who had ever smoked. And ever smoking is defined as smoked 100 cigarettes in your lifetime. So it's a very low threshold. And this was based on some other data which I haven't shown you today. And in 2007, CMS enacted the SAAAVE Act, which is screening abdominal aortic aneurysm very efficiently. Basically what this provided was a one-time ultrasound screening free of charge for 65-year-old men who had smoked 100 cigarettes, either men or women with a family history of abdominal aortic aneurysms. The challenges, though, was that this had to be connected to the Welcome to Medicare physical, which occurs within 6 months of enrollment. In 2009 was expanded to 1 year. And the test had to be ordered by the primary care provider. So this was sort of the proposed algorithm that you'd identify a patient at risk. They'd get the SAAAVE Act, they'd perform the screening ultrasound. If the aneurysm was found, they got the cardiovascular risk management. And if the aneurysm was small, which is most of them, about 60 to 70%, get surveillance. And if they met the size threshold for repair, surgery would be offered. We had concerns based on this SAAAVE Act that it was really overly restrictive for a variety of reasons. First of all, anyone older than 65 wasn't covered with the screening, but certainly were at risk, and in fact was acknowledged by the Preventative Task Force. It had to be linked to the Medicare exam. And you also had to rely on an accurate history of smoking use, which I'm going to talk to you about in a second. And because of all of this, felt that there was maybe really poor diffusion of this benefit into medical practice. This was a study that we did using NHANES data, which is publicly available survey data in the country. Basically, through mathematical modeling, what we found, and this was based on sort of 2009, that in 2009, 65% of men reported a history of smoking, but based on known mortality rates, published mortality rates, we modeled that actually 71% of patients actually probably were former smokers. And I bring this up because if you're going to ask a patient about former smoking, it's really important to dig deep, because a lot of these patients may have smoked, for 5 years, 40 years ago, and they may assume that that's not important, whereas the data actually supports, at least with regards to aneurysms, that does impart an increased risk. With this particular study, we estimated that about 700,000 who could have been offered screening weren't offered screening in the US. Almost 30,000 aneurysms would have remained undetected, and about 3,000 aneurysms requiring prompt treatment, meaning that they met size threshold, were left untreated. And just to sort of give you a sense, in the US we do somewhere between 35 and 50,000 aneurysm repairs a year, so it's not an insignificant number. We did a couple of studies that I'm going to share with you sort of to investigate how well we've done in the country for screening. This first was a look-back case. This was using Medicare data. Basically, we looked at patients who had repairs from 2006 to 2009, and then we looked back 5 years to look at all their abdominal imaging. And we defined someone with a late diagnosis as someone who had had their operation less than 6 months after their first exam, and early diagnosis, someone who had a longer interval. What we found was that almost 40% of patients underwent repair within 6 months of their initial diagnosis. This compares with European studies, screening studies, where in a well-screened population, only 12% of patients meet the threshold for repair. So over the course of the time, and remember 2007 is when the SAAAVE Act went into play, there was really a very small, non-significant decrease in these late diagnosis cases. Interestingly enough, and we'll touch upon this later, we found that over a third of patients who presented with ruptured aneurysms had a diagnosis of aneurysm for over 6 months. So keep that in the back of your mind. We also found that the primary care, we were able to identify both who ordered the tests and for what the diagnosis. Primary care providers actually had diagnosed fewer aneurysms since the SAAAVE Act was passed into law, basically from 49.8 down to 47.9%. And only half of the first images were done with an indication for abdominal aortic aneurysm. So what that's telling you when you sort of put all this together is that in the US, and I think this is probably still true to a great extent, aneurysms are found incidentally because imaging is done for other reasons. And so that represents this, this gap in what we can do for these patients. This is the second study we did. So we realized that the patients who had been operated on were probably being diagnosed late and incidentally. So what we really wanted to do was look at all Medicare beneficiaries. And we did a retrospective look, and we used natural experiment study design with a standard difference in difference analysis to look at ultrasound exams and to see the impact of the Medicare rule. I'm going to do a little aside and talk a little bit about this natural history experiment and difference in difference, because this is one of these techniques which I think is really valuable when you have administrative data. So administrative data is population-based, it's real-world practice, it's an assessment of current practices, and you can also identify population trends. It's not randomized, it's not prospective. However, you can evaluate the effectiveness by which changes in health policy change the medical practice on a national level. You can do this as a natural experiment with a difference in difference statistical analysis. And what this does is it creates a built-in adjustment for the unmeasured confounders. And so it really approximates a randomized controlled trial. And this is just a graphic illustration. So to give you a simple example, let's say you wanted to see if a state increased the a vaccination rate or a vaccination rate, and look at the outcome of the disease. You can compare a control group, in other words, a state that didn't put in a law to provide vaccinations, compare that with the state that did provide the law for vaccinations, and you can see either a jump, and that difference is the effect of the law, or you can see a gradual change over time if there's a diffusion. And this is basically what you're doing. And with this control group, that's where you control for the confounders. And that's why we call it a difference in difference, because if you're just looking at one group without the control, it may be just related to, change in practice, and people just got more interested in providing the vaccine. So this is what we did using the Medicare data, and I apologize, these are a little small, and this, let's see, you don't see my marker. So the diamonds here are our treatment group, and these are various controls. Some controls are men age 70 who didn't qualify, and others were women age 65 who also didn't qualify. And basically, the law went into effect right here, and you can see that the men went up. So there was an improvement. This was statistically significant, but I just want to point out that that these numbers are percent. So 8% of men versus 10% of men, whereas we know that there were probably 60% of men who actually would have qualified based on smoking history in this year. So even though there was an improvement, what we found on our multivariable analysis was that really only about 15% of that, it's a small improvement, and only about 15% of that improvement could actually be attributed to the rule change. The rest of that improvement was just basically due to increased use of abdominal imaging. And so our conclusion for this was that the Medicare rule was really pretty ineffective. And I just want to mention that for those of you who don't know about physician advocacy, American Medical Association, in declaration of its professional responsibilities, has stated that physicians must advocate for the medical, social, economic, educational, and political changes that ameliorate suffering and contribute to human well-being. This is really my main message for all of you today, is that we really should be physician advocates. This research that I'm sharing with you is just my attempt at a contribution. And what we did, because I was actually sitting at the time, actually I'm still on the SVS Government Relations Policy Committee, we used our national standing and our relationship with CMS and all the data that I've showed you, and this data that really demonstrated that the policy was ineffective, to really leverage this CMS to change the policy. And we actually did get them to change the policy. And so I do want to say that advocating for your patients, not always, but you can have success. And so there was a change in the policy where now, if you're eligible and if you're with a family history, or if you're a man age 65 to 75, smoking doesn't have to be tied into the welcome exam, doesn't have to be ordered by the PCP. And so now the criteria are actually consistent with the U.S. Preventive Services Task Force recommendations. So this change just went into effect a few years ago. Remember, the recommendations occurred in 2005. So it's a long process. Like everything else in academics, you need to be persistent if you want to see results sometimes. Probably within the next year or two, it'll be an opportunity for us to restudy to see if the changes had an impact. With these changes, there are still limitations with these screening recommendations, and so there's still opportunity. The first is that women are excluded from the recommendations, and it's been studied many, many different times, including a study just last year, that nobody's been able to demonstrate a benefit in women for routine screening, yet women account for 41% of aneurysm-related deaths. So there's definitely an opportunity there. Additionally, never smokers are excluded unless you have a family history, but never smokers actually account for about 1/5 of aneurysm-related death. So you can see here that even though the screening programs are trying to identify high-risk patients, there's these groups of patients who are being missed. We don't know about patients less than 65, because remember, this is a Medicare-based benefit. And this is sort of challenging because the prevalence of aneurysms in general is decreasing. I'll show you a slide in a second. Because of all of these things, we believe that better estimates of a positive pretest probability would increase the yield. So in other words, a better way of identifying who was at risk and screen them. This is a very interesting slide. The dotted line represents the overall smoking burden of the United States, and the solid line represents age-adjusted aneurysm-related mortality in men. And you can see that they're really quite parallel. So what I would say is that if the overall population-based burden of aneurysms is decreasing, but if you're a smoker, your risk of an aneurysm is no different than it was 20 years ago. So that's why it's so important to find those people who are at high risk. There have been some efforts to increase our ability to screen. This was a study where they looked at the lifeline screening. There were 3 million patients, and they basically split the study in the cohort in half and created a test group and a validation group to improve and to develop a risk score on the left. And then on the right is the ROC curve. You can see a score of 42 provided the best sensitivity and specificity, but even if you look at, and we're going to look at a score of 65, which was highly specific and less sensitive. Remember, when you screen patients, about 5% of patients have an aneurysm. So even screening with our current recommendations is not terribly sensitive. And this is actually what this study modeled. The current, The current U.S. Preventive Task Force, this is what we currently do. It's about 20 screens per aneurysm found. They estimated almost 7 million screens, 335,000 aneurysms identified. With a score of 65 and expanding the age to 50 to 84 based on all the other data that I described, you can decrease the number needed to treat from 20 to 14. You increase the number of screening by about 20%, but you increase the number of aneurysms found by almost 50%, actually maybe more than 50%. So these are efforts to try and improve the screening. This has not been adopted to date. Other ways to do this would be to leverage the electronic medical record. This is a very interesting study done by the Kaiser Southern California group, and so caveat, this is a closed medical system, so it's a little different than what university medical systems have. But basically what they did was they put in a best practice alert to identify patients who would qualify for the Medicare screening, and they wanted to see how they were able to improve their screening rates. And what they found here in 2012 was when they put in the best practice alert, and you can see overall the screening rates really increased year after year as the best practice alert was identified. We actually have a best practice alert here for our primary care physicians. The challenge, however, is that many of the patients who touch UC Davis, much like any academic center, don't get their primary care. We actually have a project that we hopefully will start this year once we hire up personnel, where we've identified through the medical record 3,000 patients who touched UC Davis who should have had screening, but who at least we have no record of screening. So it's an opportunity for us to try and impact those who touch us but don't necessarily get their care. So, in summary of my research findings and others for screening, despite these advances in screening practices, there still remains significant missed opportunities in the U.S. population and the U.S. Medicare population for improving screening and therefore overall aneurysm care. I would say that screening for aneurysms is not ineffective. We've just really ineffectively screened to date. It remains common for aneurysms to be diagnosed incidentally and when they are either at size threshold or really much past the size threshold for repair and therefore an increased risk of rupture. And there's opportunity exists to minimize aneurysm-related death with more effective screening and surveillance. And just a real quick word on surveillance. As I mentioned, over a third of patients with rupture have been diagnosed for over 6 months. And this is important because most of these patients, when they're diagnosed, have not met the threshold for repair. This suggests real issues with surveillance. This is another area of interest in mine, but it's a topic for another day. What I do want to do, though, is touch upon some other areas that we've been able to use these techniques to educate the public, the public, educate the medical public, and to try and understand how health policy decisions impact care and vice versa. So the first is a study where we looked at office-based laboratories for vascular surgeons. So about 5 or 10 years ago, there was a transition for vascular surgeons to own their own vascular labs where they're doing outpatient angiography and outpatient endovascular treatments. And this has been studied in other areas, and basically what these studies show, not surprisingly, is when physicians own their practices because they can collect tech fees as well as pro fees, that the volumes go up. And so there's always a concern when one does this that you're actually increasing the cost of care without necessarily increasing the quality of care. And so we wanted to study this with the physicians, and we were able to create this very unique data set with Medicare, where we identified a control group of physicians who remained treating in the hospital throughout the study period, and we identified a second group of physicians who at the beginning of the study period were in the hospital, and at the end of the study period were in outpatient labs. And so what we were really looking at was not how the outpatient lab affected their care, but how moving to the outpatient lab affected their care. So this is really a study on physician behavior. And basically what this shows is, so that these top two are the number of cases per patient in 30 days and the number of cases per patient in a year. And the vertical line in the middle is the switch date. So you can see the people who didn't switch basically were stable across the time period. Those the switchers, they actually had higher volumes before they switched compared with controls, but even higher volumes both at 30 days and at 1 year after they switched. So there was a propensity for this group to do more cases that was accentuated by moving into an outpatient lab. And then if you look at the number of patients with repeat studies, percentage of patients with repeat interventions at 30 days, again, you see this bump in the physicians who switched. So this is basically demonstrating that switching really altered the behavior, the way that the physicians cared for their patients, because presumably the patient population didn't change across the unit. What we also saw was that over the course of our time frame, the overall number of procedures went up, and the proportion of procedures went up most in the outpatient lab compared with outpatients or hospital or inpatient hospital. And those are basically the same group. It just, as we were talking about today, as how the patient is defined, outpatient or inpatient. And then the number of atherectomies, which is the most highly reimbursed procedure, especially from the tech fee standpoint, also increased. And so what we showed was that basically by transitioning physicians into these physician-owned OBLs, the volume of interventions increased, and there was increased use of atherectomy. We did, however, see that there were lower hospitalization rates and lower major amputations both at 30 days and 1 year. There was no statistical differences in mortality, and the costs actually in the paper that I won't show you today increased. So what this basically showed was that there was a cost and there was a benefit to this movement, and I think it quieted a lot of the critics about, well, we're just spending a lot of money for not much gain. At least we were able to demonstrate there was clinical improvement. These techniques can also be used outside of vascular surgery, and so I'm going to end my talk over the next few minutes for sharing some studies that I did with the trauma service at UCSF. And if those of you who've been to the AAST the last couple of years, the slides may look familiar. So in October of 2018, American College of Physicians put out a statement saying that firearm violence continues to be a public health crisis in the United States that requires the nation's immediate attention. This comment did generate a great deal of attention both from the NRA and from physician groups. For those of you who know, this is our lane. This is a consequence of this. That's beyond the scope of my talk this morning. However, we did want to do some studies to understand the relationship with gun laws and firearm-related violence, and also with gun sales. And so the first study is a study where we were looking at a law in 2012 in California that banned open carry of unloaded handguns. Open carry of loaded handguns in California had been banned since the 1960s, but until 2012, you were allowed in California to have open carry of a unloaded gun, and the law changed in 2012. Just as a background, there's not a lot of research because there's no federal funding that's allowed for gun research. That's a whole another area of topic. But for what has been done, there's been fairly good evidence to support that states with stronger gun laws have lower firearm fatality rates, and California is really one of the strongest groups of gun laws. And we really wanted to see if in a state with strong gun laws, if adding this additional ban would really make any difference. And so this was again a difference in difference technique, the same technique that I described, and we compared with a variety of other states because we wanted to compare with other states that had restrictive gun laws and states which didn't have restrictive gun laws. And each state's actually graded. It's called a Brady grade, if you're interested. And then we needed to adjust for other laws that took place over the course of the time period in other states. What we found in our control states was that the overall, and these are case fatalities per 100,000 persons. In our control states, the case fatality rate went up 1.8%, whereas in California, the case fatality rate actually went down 3.7% since the institution of the law. This was a statistically significant finding. And we estimated in California over those 3 following years that there was about 338 fewer deaths, small but significant amount, and over 1,000 non-fatal hospital visits. And so, our conclusion from this was, even in a state with fairly restrictive gun laws, additional gun laws did decrease the gun-related injuries and fatalities. We were in a separate study. We were fortunate because in 2016, California released actual gun sales for a 20-year period. This was released by month. No other state's ever done this. And we really wanted to take this as an opportunity to understand how gun sales had an impact on violence. And actually what we decided to do was to look at the effect of these mass shootings on gun sales over this 20-year. And this is again, this is a California study because California is the only state that has released this information. And so this is the data. Each dot is a month, and you can see that basically, and the blue dotted line is where the assault weapon ban expired. It was a 10-year ban that expired in 2004. You can see that for the most part, until 2011, the monthly gun sale rates were about the same, but there are a few spikes here. Interestingly enough, December had the most sales in 17 out of the 20 years. We're not exactly sure why that is. Part of this could have been because of changes in legislation, which generally take effect in July, but part of it, I suppose, could have been the holiday season as well. We didn't have that kind of detailed information. And right here between July and January of 2011, a couple things happened, and that is where the gun sales started to increase. And there were 2 mass shootings about. They started to increase in 2008, and I'll show this in a couple of slides, but they really started to increase in 2011. And there were a couple mass shootings about five weeks apart in two separate areas of the country. One of them involved an AK-47, and it was the most, at that time, it was the most deadly AK-47 related mass shooting since the assault weapon ban expired. And it created a lot of press, and we think that may have been the turning point. Now, interestingly enough, this spike right here is right after Columbine. That's the Columbine shooting. And then each of these is are either December or other mass shootings. All these marks are some of the deadliest of the mass shootings. Right here is Sandy Hook. And what's interesting, you see this huge spike right after Sandy Hook. And we believe that part of that was because of the Sandy Hook, but part of that was because at the time, 40 federal and 1,500 state bills across the U.S. were introduced in the 6 months following Sandy Hook. So there was definitely a concern. There was certainly a concern that some people weren't going to be able to buy firearms, and so there's a big spike in sales. Interestingly, none of those bills passed, not a single one. So to go to your point about the mass shootings, and mass shootings can be defined in a lot of different ways. We define mass shootings for this particular study as single assailant, 4 or more fatalities, not including the assailant. And this is one of the variety of standard definitions. And so this is the graph of mass shootings since 1996. A third of them have occurred since 2012. So if you break this up, up until 2012, there was about 3.3 events per year. You can see it started to sort of increase in 2012. From 2012 to 2015, it increased to 7 events per year. From 2015 to 2018, 12.8 events per year, a statistically significant increase. And I'll just say we're on pace this year to have 29. So we're not going down. And then just to superimpose the graphs, this really sort of gives you a sense of the overall pathway of gun sales and the mass shootings. There definitely seems to be an association. So our conclusions for this study were that mass shootings there have been an exponential growth since 2012. Simultaneously, there's been an exponential growth in gun sales since 2012. And the largest sales increase seemed to precede these legislative changes. Why is this? It's complicated. It's obviously complicated. There's a lot of interactions. I believe that at least 2 important aspects are first, fear of personal harm and the perception that a personal firearm is protective. So people get afraid from these events and they want to go out and buy a gun for their protection. And then the other is that these events lead to the gun regulation, which makes it more difficult to acquire firearms in future years, so it sort of feeds the fire of firearm sales, so to speak. It's just another example of how this type of research can really open eyes and have people understand what's going on. So, in summary, research with this administrative data can and will improve our understanding of how we impact our population with the medical care that we provide. Knowledge gained from these studies can uncover gaps in current practice and can influence health policy. In order to do that, you have to have a place at the table, and this is really key in these U.S. health policy decisions, as they can have a significant impact on how we deliver health care. In my screening example, this was our National Society working with CMS over the course of many years to institute some changes. Physician advocacy is a professional responsibility on many, many different fronts for the safety and welfare of our patients and our communities, communities of patients and our patients within our community. And we as physicians, we do have a voice in the welfare of our patients in the communities if we choose to use it and if we use it wisely. So thank you very much.
So thank thank you, Dr. Mell, and thank you on two accounts. One, for being our pinch hitter on short notice, and two, for giving this great demonstration of, in many respects, the reason why we are in academic medicine, which is to have impact. And I think your talk this morning, our conversation, we had three great examples. Our conversation about the immunotherapy for reducing infections and Ian Brown's work as well, really speak to the different ways one can have impact. And that's really why we are all in an academic environment. And so thank you very much for that and the great examples. We are actually now in the starting phases of reopening our recruitment for a sort of PhD leader for our health services research work, and I think it's totally appropriate that you happen to be leading that search as well. So I think this is great. Do we have some time for questions? Dr. Ali.
The first is a comment, and I would just put maybe 1,000 lines under your advocacy at the local level, regional, national, whatever role you can take. I think just have to do that. It's high time.
And this is plug while you're doing that. If you haven't joined the American College of Surgeons pack, you can do, if nothing else, you can send $50 and make a contribution. We'll let him finish, then I go to you.
The question, Matt, is about the AAA screening. I wonder if you are getting a sense from your work with the society that the new ACO type of arrangements coming from CMS are going to impact that, and more specifically, will MSSP members at the different programs, is that an opportunity to get that put in? Because there's a lot, even for us here, what we're trying to implement, there's a lot of screening in that, depression and all kinds of stuff for CMS members. Are we going to see AAA in that, or are you guys working toward it?
So we're working towards it. I actually think that the biggest challenge, so I think the reason why screening programs in the UK and in Europe have been successful is that they are direct outreach programs to the patients. So the patients get a postcard in the mail saying, you qualify for aneurysm screening, you have a risk of an aneurysm because of X, Y, and Z. If you want to be screened, call your hospital and get it set up. And they get a 75 to 80% success rate in if you look at the invitations versus those screened. I think trying to go through PCPs is a mistake. I think that, and in fact, what we're trying to do with our 3,000 patients here is do a direct outreach to see if we can actually demonstrate in the U.S. in an open system that direct outreach will really have an impact, because the benefit's already there, and it would be considered standard of care.
Dr. Coconut.
I just want to reiterate on the advocacy part. Please join your Northern California chapter ACS, because we actually have a very active advocacy committee, and they join all three ACS chapters in California, and they all converge on the Capitol, which we're right here. We need to be there as well in April of next year for Advocacy Day.
Yeah. Well, we have a great opportunity for advocacy here at Sacramento, because not only are we in the state capitol, but our representative to Congress is a physician who is part of the physician advocacy group in the House. And so we actually have an avenue, both locally and actually nationally, to at least get some attention and provide some input on some of these important issues.
I have to say that we have three tracks for at least our general surgery residents, which was all we had when I came here, in terms of public policy and health services research, as well as rural global health, and then our basic science. But we really never have had anybody take up the advocacy pathway as much as I had envisioned, exactly because of this, because of our unique position in the largest state in the country. I used to say, Dr. Belanti will know, and potentially the most screwed up healthcare state in the country. So what a great platform platform for health services research and public policy and things like that. So it's just a plea that, and we have, through our Center for Healthcare Policy and Research, through our departmental efforts, now they're really tremendous resources for this kind of work. And so there's lots of ways you can have impact beyond just basic science, although, as you know, I think that's an incredibly important avenue as well. But all of these are really ways to do it. So, thank you again. Really spectacular.
Thank you.